Good morning. I'm here from TCT 2017 in Denver, Colorado, and I'm Vinod Thourani, the Chair of Cardiac Surgery at MedStar Heart and Vascular Institute in Washington, D.C., and also the past Chair of the Council for Cardiac Surgery from the ACC. The current study by Dr. Barron on behalf of the EXCEL investigators evaluated quality of life after PCI or coronary bypass surgery on the treatment of left main coronary artery disease. As a reminder to the listeners and watchers, the EXCEL trial randomized 1,905 patients with left main CAD to either a second-generation drug-eluting stent or coronary bypass surgery. The primary endpoint, composite endpoint, of death, stroke, or MI were similar in both groups as a median of 3-year follow-up. While the rates of repeat revascularization were higher in those with PCI, overall there was no major difference between the two. The premise of the current study was to determine the differences in quality of life changes. Quality of life is assessed at baseline and at 1 month and then also at 3 years. And what they were able to find is by using disease-specific health status instruments, and they also used generic health status instruments, a variety of 5 tests that were utilized. When we look at the results at 3 years, and not surprisingly, we found that PCI resulted in significantly better healthcare status when compared to CABG at 1 month, probably because you have the stress of coronary bypass surgery and the sternotomy. And this was apparent in all quality of life scales. However, at 3 years, both PCI and CABG led to clinically meaningful and statistically significant improvements in health status. At 3 years, overall, there was no difference, and this is the important portion, there were no difference in quality of life between PCI and CABG as it related to age, gender, nor diabetes mellitus. Interestingly, higher rates of repeat revascularization with PCI in prior studies suggest that CABG provides superior long-term angina relief in patients with complex CAD. In this study, there were no significant differences in any disease-specific or generic health status measures at 3 years between the treatment groups. And for instance, when you compare this with Syntax and the Freedom trials, the EXCEL trials showed no difference in long-term angina relief between PCI and CABG, while in Syntax and Freedom there was, and that was better for coronary bypass surgery. Similarly, in the EXCEL trial, there was no difference in subgroup effects, while in Syntax and Freedom trials, CABG was better with greater anatomic complexity. As I think about how this study impacts surgeons and cardiologists, I think this important work really fills an evidence void on the patient-reported outcomes for patients with left main disease facing a revascularization choice. These results suggest that both PCI and coronary bypass provide comparable intermediate-term outcomes for appropriately selected patients with left main coronary artery disease. I think it remains very important for the heart team to decide what is appropriate for both PCI or coronary bypass surgery. And I think further studies are also needed to evaluate the durability of these health status benefits with PCI compared to coronary bypass surgery beyond 3 years in selected patients with left main disease, especially those that are younger, that we expect to have a long life.